So we're going to go ahead and get started for session number 2. And I just want to give some people some numbers. Actually, we've had over 50 people participating virtually here. And for those people participating virtually after this session, we'll have lunch. But I guess people in the virtual world, some of them actually are from the East Coast and maybe actually having dinner or so. So this next session is actually focusing on an important area in the area of epilepsy, and more specifically sort of epilepsy genetics disorders. And so we'll actually have a quite diversity of our presenters. We'll have a geneticist who is a neurogeneticist who's been involved with our program for nearly a decade. We developed an epilepsy genetics clinic here. And Stephanie Randle, who's the medical director of our epilepsy surgery, will also be presenting. So we'll have a neurologist. And finally, we'll even have another neurosurgeon, Jason Hauptman, who will talk about the surgical approaches, not only to these rare genetic epilepsies, but also resections as well. So certainly, particularly in the epilepsy world, genetics and genomics has played an important area. Particularly in pediatric epilepsy. And so this is a recent review of the importance of genomics and genetics in epilepsy, particularly in pediatrics, that when I date myself, but in the early 1970s and 80s, going through medical school, it used to be said 80% of epilepsy, particularly in children with idiopathic, we didn't know the underlying cause. And now, if you look at the recent review from 2014, number one is one of the things that has really identified causes of epilepsy is imaging. So imaging has really identified what we now refer, and we see more in pediatrics, are often referred as brain malformations, cortical dysplasias, or subtle changes in the brain, sometimes subtle and sometimes not so subtle changes in the brain that often can cause epilepsy. So imaging has revolutionized our ability to identify these, but also many of these also have an underlying genetic component that you'll hear about from Dr. Mirzaa. Autoimmune causes of epilepsy has also been increasingly identified, but more importantly, genetics and genomics has really identified that large group of patients, particularly in the pediatric age group, that underlying genetic causes are being increasingly identified. And that's where groups like the Rare Epilepsy Network is important, because there's almost 40 or 50 of these rare epilepsy syndromes that are often genetically determined. So it's important to identify and make these diagnoses for these rare epilepsies, to get the kind of support, and more importantly, as we diagnose these rare diseases, to start targeted so-called precision medicine treatment. So session 2 will start with one oftentimes a genetic cause of epilepsies, what conditions called hemimegalencephaly, which is a brain malformation, or focal cortical dysplasias. That will be presented by Dr. Mirzaa. Stephanie, who's the medical director of our epilepsy surgery and also of the tuberous sclerosis program, will talk about tuberous sclerosis, which we know is not as rare as some of the real rare diseases, but fairly common. But 80 to 90% of individuals with tuberous sclerosis have epilepsy. And then Dr. Hauptman will talk about the potpourri of both minimally invasive and more invasive neurosurgical approaches that, more importantly, I think in many individuals, as was shown in the initial case, potentially can offer a cure for their epilepsy. And so that will be the last part of the session. And then that will be followed by a panel where people can ask the questions on this portion of the session. And then this will be followed by lunch. So let's go on with the program.
Hi, good morning. It's a pleasure to be here. My name is Ghayda Mirzaa. I'm one of the geneticists here who's been working with the team, and I'm delighted to be speaking to you today. So when it comes to genetic considerations for children who've had epilepsy, the focus of the title of my talk is really pediatric surgical epilepsy, but a lot of the concepts and considerations apply to children with epilepsy in general, regardless of whether they're surgical candidates, if you will, or not. So I'm hoping to highlight some of the considerations and things we think about when taking care of these children. I do not have any disclosures to make. So one of the first kind of obvious questions that many people may ask is, well, you know, if my child has epilepsy and we're dealing with this complication and things like that, why do we even consider genetic testing? Where does genetics fit into the care of these children? And over the past few decades, particularly with the advent of more advanced genetic testing methods and technologies, we now have more than enough evidence to show that genetic variants or genetic changes are common causes of epilepsy in general. So a significant fraction of families who've had to deal with epilepsy, their children may have genetic variants or genetic causes that could explain why their child had epilepsy to begin with, sometimes with additional comorbidities, of course, such as autism, developmental differences, birth defects, and so on and so forth. The second thing we've really appreciated over time taking care of our families is that genetic findings can actually contribute to the severity of epilepsy, as was, I think, highlighted by the speakers earlier this morning. And it's also important for the recurrence risk for the family. For many families who are interested in having more children, this is really a very common question and concern that they might have, is what is the likelihood that my next child will have epilepsy? Or my existing children might have epilepsy for that matter. And then lastly, and this is really where a lot of our research and clinical care has kind of been really focused on over the past few years, is that we want these genetic findings to be there not just for a diagnostic perspective, not just to understand the root cause of epilepsy, but more importantly, we also want to take better care of our children based on these genetic findings. And there has been over the past few years some really exciting advances on that front to show that genetic findings do actually impact and allow us to adopt a much more targeted approach to the care of children, both medically and surgically speaking. So this is really, I think, the big dream and big hope of genetics, is that it's just the first step on the path to better therapies, better management, and better seizure control. So when we talk about brain malformations as a cause of epilepsy, you know, for many children, they undergo a brain MRI scan as part of their course. And a number of children might have structural abnormalities or structural differences in their brain. And here, there's really a broad spectrum of involvement that we can see, anywhere ranging from a really diffusely enlarged brain that can be dysplastic. So some kids might have what's called macrocephaly or megalencephaly, so brain overgrowth with cortical dysplasia. And some kids might have much more localized involvement of the brain. So something where half of the brain is involved, such as hemimegalencephaly, and even more focal forms. So on the near, like milder, you know, smaller end of the spectrum here, I shouldn't say milder actually, because we now know actually that sometimes the size of the lesion doesn't always correlate with the severity of epilepsy, but smaller areas such as what is known as focal cortical dysplasia. Now, classically, decades ago, particularly in the genetics field, a lot of these were considered distinct syndromes or distinct entities. So children were kind of treated very differently depending on what their brain MRIs showed and what their physical examination showed. But when we started to do genetic testing on these children, what we now know is that a lot of these clinical pictures are actually related to genetic changes in the same pathway. And that's actually extremely valuable and helpful when we talk about therapeutics, because when we can actually target cellular pathways by certain drugs or molecules, so now that we know that a lot of these children might actually have links between them in terms of the genetic causes, this has actually allowed us to pursue therapeutics in a much more informed way than before. So this is kind of like the broad spectrum of brain malformations that we see in our clinics. We now know that a lot of children might have genetic changes in some of the cellular pathways that are really important. So here I'm actually showing one example. It's by no means the most common across the board, but it's just one representative example of a really common pathway that's affected in children, which is known as the mTOR pathway. The longer name is the PI3K-AKT-mTOR pathway. And in this image here, you see multiple genetic nodes. So there are multiple genes, multiple genetic codes that are part of this pathway or part of this network. And we have genetic changes across many of these genes in this pathway. So certainly it's not just one gene that is involved, but a whole host of them. And what's really important is that for many of these children, what we see is that there's activation of this pathway. This is a pathway that's highly involved in growth and development. It is extremely important for brain growth, as well as brain activity and brain function. So for many of the children, the types of genetic changes we see cause this pathway to go into what we call an overdrive mode. So it's overactive. And as a result, some of the kids might have a larger sized head, for example, on top of their epilepsy. And so the mTOR pathway is a really great example of a genetic pathway that we see a lot of mutations in children who've had epilepsy. And knowing that a child might have a mutation in this pathway can actually be quite helpful for their care. So when we talk about also genetics, a lot of families ask a very obvious question as well, well, if my child has a genetic change, how did this occur? And here we have actually a very important kind of conversation sometimes to have with families, in that most of the time when people think about a genetic mutation that happened in a child, we think about an early genetic event that happened very early on in pregnancy or sometimes even preconception. And typically, the most common way across the board for genetic conditions to happen is that a genetic mutations happen at the very early stages of fetal development. So sometimes it's right at fertilization, sometimes it's actually in one of the gonads of one of the parents. And as a result, the child from that pregnancy would have that genetic change in all of the cells, and this is shown by the green coloring here. So 100% of the child's cells would have that mutation. This is certainly a common way for this to happen across many epilepsy syndromes. When we think about the brain malformations that cause epilepsy, and a lot of the kids who undergo surgical, especially resection, there's another way that genetic mutations can happen, which is that these genetic changes can happen later on in fetal development. So as a result, it's typically after a few rounds of cell division have happened. So not all cells of the child would have that genetic change. And as you can see here, as shown again by the green color, it's basically a fraction of the cells that might have the genetic change, and the genetic change might not be present elsewhere in the body. So if that population of cells that has the genetic change happens to be brain cells that lead to the development of a critical part of the child's brain, that part of the brain might not only be structurally abnormal, but as a result, it might actually be epileptically active or electrically active and cause epilepsy that could be sometimes extremely challenging to treat. And so this is kind of a very, very common way for some of the surgical epilepsy children for them to have epilepsy, is that it's a later genetic event that happened during pregnancy. The term for this type of genetic mutation that we use is mosaic, meaning that the child will have genetically distinct populations of cells. Some of them have a mutation and some of them don't. And in that sense, we do know, and I'm kind of showing here like a piece of art of the brain, we do know that our brains are actually highly mosaic structures. Not all brain cells are the same, and certainly genetically, they're not all the same. And that is certainly the case for our children as well. This is actually, we've seen this now in a number of children we've evaluated at Seattle Children's. This is what was one of our actually children that we've evaluated. Many of us were involved in this child's care, who's now a young man, who actually had intractable epilepsy and underwent surgical resection. And the family was extremely generous to agree to donate some of the surgically resected tissue for genetic research at the time. We didn't have this as part of clinical care because it was all in the research realm, and now thankfully we've transitioned to clinical standardizing genetics as part of their clinical care. And what we found when we tested the brain tissue is that he had a mutation or a genetic change in a gene called mTOR, part of the mTOR pathway, and the level of the mutation, it affected different percentages of cells depending on which region of the brain that was assayed by genetic testing. All of these regions were surgically resected, and we see that the level of the mutation, or the percentage of cells that had the mutation, ranged from 9% at the maximum to 0% in some of the surgically resected brain tissue. And this was quite helpful towards understanding the cause of epilepsy for that child. So as a field in genetics, we now know that our brains are highly mosaic structures, that children can have genetic changes that can be present in their brain tissue that can trigger their epilepsy directly. And interestingly, these genes can actually have really important pathways or networks. A lot of these networks are shared with cancers in adults, for example, And this kind of gives us a really good opportunity to think about therapeutics in a much more informed fashion, as I mentioned. So we've actually been asking two big questions as a group here, as our multidisciplinary team has been really working on two fronts, if you will. And I kind of show them again in a mosaic piece of art to kind of show this concept again of mosaicism in our brains. But the two big summits, if you will, that we've been trying to really climb here is, can we reliably detect these genetic changes in our children to provide that knowledge to their care teams as well as their families? And are there functional differences between these genetic changes that have treatment implications? Because again, at the end of the day, finding the cause is extremely valuable, but it's not the end of the road. What we really want to go towards is better therapies and more improved surveillance and management. So here we actually have a couple of really important considerations when we evaluate children in our clinic. So when we see children who have had really intractable epilepsy and their brain MRIs have been abnormal, showing some of these structural lesions, we kind of think about a couple of things before we proceed with genetic testing. First, we want to detect a method. We want to use a genetic testing method that is very sensitive towards finding these genetic changes that are present in only a fraction of the cells. So the sensitivity of the laboratory method that we need to use. Next, we know that there are a number of genes that can be present in any given child. So that means oftentimes we don't just test for one thing, we try to test for many genes at the same time if possible. And lastly, we have a really kind of comprehensive approach about thinking about what the child has, what does their physical examination show, and which sample should we test from that child. Should it be a brain sample that was surgically removed, or should it be a peripheral sample like blood or saliva, which is usually the most common way. So I'm going to share with you here some of our findings from actual, experience over the past few years in the hope that it kind of shows some of the results and some of the relevance to care for these kids. So a few years ago, we've been collecting and enrolling families in, again, at the time, it was all part of research. Now it's part of their clinical care, but we have a biorepository of hundreds of samples from children who've had really severe and intractable epilepsy. And so for many of these kids, we have surgically resected brain tissue that could be fresh frozen from the surgery. But then again, for a lot of families, the most practical thing is really to give a sample from blood or saliva. And for some families, if their children have vascular lesions or other skin markings, they might undergo a skin biopsy as part of their care. And so what we did was that we tested all of these brain tissues using what we call an mTOR panel. We took the most common genetic variants we see in the mTOR pathway, and we wanted to test these samples, this cohort of samples, for these mTOR mutations. These are really common genetic variants across the board. And I'm showing here the breakdown as well in this pie chart here, the breakdown of the samples we have. So obviously, again, we know that a lot of these genetic variants might actually be very tissue specific and only present in the brain of the child. And this is why a lot of the representation here is for brain tissues. And then we examined also what was their neuropathology diagnosis. So when these samples were examined in the laboratory, what were their neuropathological abnormalities, as that's a really important piece of our evaluation. The genetic testing piece, I won't go too much into the details of this, but this is where, again, the genetic technologies over the past few years have been really helpful in that we now have much more sensitive methods to detect genetic variants. So one of the methods, for example, that we've employed is something called droplet digital PCR. And for those of us who might be able to recall some of our molecular biology from high school and undergrad, for example, this is actually a very sensitive DNA PCR method, which allows you to fractionate your DNA molecule or the child's DNA sample into multiple droplets. Ideally 20,000 droplets. So imagine from one sample, you get 20,000 readouts from that child's sample. So essentially, it's an extremely sensitive method. So if there's a DNA change that's present in only a fraction of cells, let's say 5% of cells, this method, if done correctly, hopefully should be able to detect that. So we used droplet digital PCR on our samples to actually see if we can find genetic changes. And what we found was that in about 20% of children, at least 20% of children had genetic changes in the panel that we deployed and that we used. And this was actually extremely valuable. So that's almost 1 in 5 kids would have a genetic change in one of the genetic variants that we tested for using this method. And for many kids, of course, we had more than one brain surgical sample to actually test. And this was actually extremely valuable because what we also saw is that the level of the mutation, even from the same surgical field, it actually ranged from up to 15% of cells to down to 0% of cells. And that raises a whole range of questions about what does that mean for that child if it varies so much within the brain tissue itself. So this is kind of a quick representation of some of our genetic findings. And in this graph over here, we're summarizing some of the genetic changes that we found. So they include mTOR, the mTOR gene, as I mentioned, PIK3CA, and AKT3 are other examples of other genes. I'm going to show quick cases here, just a couple of quick cases to kind of show some of like practical concepts. I know that these genetic findings can be sometimes quite complicated and hard to understand. But these are just a few cases that kind of exemplify some of these findings. So this is a child we had seen at Seattle Children's who had hemimegalencephaly, so 1/2 of the brain was involved, and additionally had this vascular marking on the skin. Which again, for us in genetics, when we see our children in clinic, we try to take a very comprehensive physical examination to see if there's any other features, any other changes on their exam that might clue us in towards some of the genetic causes we think about. So you see this vascular marking here on the leg, in addition to, of course, the brain MRI changes. So we used our panel, a genetic testing panel that's actually deployed at the University of Washington. And we tested, after the child had brain surgery, we tested as many brain tissues that we could have that were extra from the surgical resection at the time, in addition to a skin biopsy sample that was performed on the vascular malformation. And what we found was a genetic change that's a really common genetic change in a gene called AKT3. And what I'm showing here in this last column is the percentage of cells that had that genetic change. And what hopefully you can see is that in the skin sample, the genetic change was only present in 1% of cells, which is extremely low, even though that skin sample had a vascular change to it. So it wasn't by quote unquote normal skin. In the brain, however, the genetic change was present at a much higher level, ranging from 10 to 18%. And this is important for clinical care as well, because if we were to send a skin sample all the time, we might actually miss a 1% result, right? So it's really valuable to think about what is the sample we're sending for testing that will optimize the chances that we would find that genetic change. And obviously, the gold standard is testing brain tissue when available. This is actually another child who we had who was referred to us from out of Seattle Children's. It was referred to our research program from out of state. And unfortunately, this child was not a surgical candidate because their brain MRI showed bilateral findings, really severe dysplasia, severe changes on both sides of the brain. And the child sadly passed away shortly thereafter because of severe intractable epilepsy. The child had a larger head size, so we kind of were suspicious early on that there might be a chance that there is a genetic change in the mTOR pathway, for example. And we found, long story short, this was a diagnostic odyssey, we found 3 genetic changes actually in that child on testing the brain tissue using our droplet digital PCR technology. We found a genetic change in AKT3, as well as 2 genetic changes in PIK3CA in the brain tissue. And these were actually highly mosaic, which means they were only present in the brain tissue and not present elsewhere in the child's body. And the last example I'll show before kind of wrapping up as well is that sometimes families go through a very long diagnostic journey. And this is why I think it's kind of helpful to think about genetics early on. There is access issue, of course, with genetic services across the country. So it's not always easy to find a geneticist or to meet with a geneticist early on in the child's care. But sometimes families do go through a longer journey of finding their child's cause. So this is another family whose child had early onset epilepsy and a large head. They underwent rounds of genetic testing across the years. All of them were done on peripheral tissues, blood, saliva, and they were all negative, essentially. And then finally, the family agreed to do a skin biopsy. It was not preferred early on because it was felt to be invasive, which it is, but at the end of the day, targeted genetic testing was done on the skin biopsy, and we found an mTOR genetic change that explained the child's developmental differences in epilepsy after many years of care. So this is kind of just to highlight some of the complexity that can occur sometimes in the care of children with epilepsy. And importantly, one of the big questions families ask is, well, what does that mean? And what we found is that having some of these genetic changes might actually correlate with earlier onset of epilepsy, sometimes more severe epilepsy in children, and an earlier or a faster course towards intractability, if you will. And this is something we found in some of our studies as well. I will actually skip just in the essence of time and to allow really room for hopefully discussion. We do have a lot of now data to show that there's important functional differences depending on the gene that have treatment implications, so including with some of our drug targets. So there's a class of drugs called mTOR inhibitors that we can use for children who have had intractable epilepsy due to genetic changes in this pathway. A great example is a condition that Dr. Randle will talk about called tuberous sclerosis, and mTOR inhibitors have been used in this condition for many years. And we have now started to use it in some of our children with intractable epilepsy due to other syndromes within the pathway. But I will actually skip through a couple of slides just because, again, in the spirit of time, where we have some functional data about the use of mTOR inhibitors in this pathway. I think Dr. Randle will cover a little bit of that as well as some of the other talks later as well. And I'll kind of wrap up with showing this slide here, which is that, a lot of our families, again, go through genetic testing as part of their clinical care. The earlier these conversations can start, we think the better. Many years ago, the families would go through a very long, again, journey with genetic testing. We now have much more advanced genetic testing, such as exome sequencing and something called genome sequencing, where we can sequence thousands of genes in one go, basically. So these are really more newer approaches. And when we think about these epilepsy disorders, we have to think about tissue-specific genetics, we have to think about deeper testing and brain tissue-specific findings, really. And how do we correlate that with the child's history and the child's course? So we typically try to offer pretest counseling early on for families where they meet with a genetic counselor or a medical geneticist and have conversations about this. And then we offer genetic testing if we think it's appropriate. And then afterwards, of course, we will offer, of course, post-test counseling. If we find a genetic change that impacts their medical therapy, we will then hopefully get them enrolled and plugged in the appropriate services based on their genetic findings. So all of this is really kind of new models of care that we have implemented in our epilepsy genetics clinic and neurogenetics clinics at Seattle Children's. And all of this work could not have happened without the multidisciplinary team that, of course, you've met with earlier this morning as well, and you'll meet with the rest of the day. But really, I want to just kind of quickly acknowledge, of course, our patients and their families, because with genetics, we had to go through, as I mentioned, research for many years to kind of build the level of evidence that we now have that we should offer this routinely as part of their clinical care. So if it wasn't for their generosity and contribution to our research, we wouldn't have all this knowledge. So thanks to them, first and foremost, and then our wonderful team, both in neurology, neurosurgery, our neuropathology colleagues, and our laboratory medicine colleagues who have been extremely helpful in developing the genetic testing methods that we now use. And with that, I'll thank you for your attention. Thanks.
All right. So now I'm going to talk about tuberous sclerosis complex. I have no disclosures. My objectives today will be to define TSC, highlight the neurologic complications of TSC, review the updated guidelines, and talk a little bit about our program here at Seattle Children's Hospital. So what is TSC? And as we all know, Dr. Mirzaa just did a great job reviewing the mTOR pathway. But TSC is a multi-system neurocutaneous genetic disorder. Multi-system meaning it can affect almost any organ system in the body. Neurocutaneous, as we saw in some of our last clinical examples, are those disorders that can affect the skin and the brain. And then genetic, we know this disease has an underlying genetic cause, either by a mutation in the TSC1 gene or the TSC2 gene. Together, these two genes are responsible in forming the TSC protein complex, and that helps regulate mTOR, as Dr. Mirzaa was just discussing. And so as we know, the mTOR pathway is responsible for cellular growth and proliferation. And so when this pathway is not regulated, cells in the body tend to overgrow without much regulation. And that's one of the important roles of the TSC protein complex, is to put the brakes on the mTOR pathway when needed. So focusing on the neurologic complications, there are going to be four main areas that I'll talk about. First are the cortical tubers. These are pretty common, actually seen in almost everybody with TSC, up to 90% of patients. And I have a couple of examples here on the MRI scan. You can see areas where there are lighter color changes on the brain as compared to the opposite side where you may not see it. And those are areas where the cells themselves either did not grow normally, or when the brain was forming, the cells did not get to the right location. And so overall, we're not too worried about these areas of dysplasia, with the exception that they put a child at an increased risk of seizures. So we don't think that the areas of dysplasia themselves cause the the neurodevelopmental complications, but certainly can contribute to the epilepsy component. And so in TSC, up to 90% of people will have epilepsy, and the type of epilepsy they have may depend on the age. And so in this nice study done on the East Coast by Dr. Davis's group, it was a retrospective study that looked at multiple centers and asked, okay, when did kids present and with what type of seizures did they present with? And so on the bottom, you can see the age in months, and on the y-axis, you can see the prevalence. And so in young kids under 12 months of age, the incidence or the onset of seizures is pretty high. Actually, it can be up to 80% of these kids. And if you're presenting with a seizure under a year of age, the type of seizure you're likely going to present with is either infantile spasms or focal seizures. Patients can also have other seizure types. Many kids will have a mixed seizure type, so not just one type, but may have both focal and generalized seizures, as Ms. Fenstermacher nicely explained earlier today. So how we treat epilepsy in our patients with TSC, it depends on what type of seizures they're having. And so if they have infantile spasms, then vigabatrin is typically our first-line agent. And if they have focal seizures or generalized seizures, we may choose a conventional anti-seizure medication based on the type they have, as well as based on the side effect profile and tolerability by patients and families. Often, the conventional anti-seizure medications don't work, and we know that in up to 60% of kids with TSC, they may have medically refractory or intractable epilepsy and may need a second-line agent such as an mTOR inhibitor, like everolimus is an example. And Epidiolex is a newer medication that's been approved for the treatment of children with TSC and refractory epilepsy, and that's our pharmaceutical form of cannabidiol or CBD. As I mentioned, up to 60% of kids won't have a favorable response to medication and may need to move on to a different type of therapy, which may include epilepsy surgery, which Dr. Hauptman will talk about in our next talk, neuromodulation, as Dr. Goldstein and Dr. Bozarth nicely discussed earlier, or the dietary therapy that Dr. Lacroix will discuss a little bit later today. The next main structural complication of TSC includes subependymal nodules, and this can be seen in a large majority of patients, up to 90% with TSC. These are not quite as concerning on their own. You can see there are these areas of growth in the middle of the brain in the ventricle. They come out of the ependymal lining. The problem is if they grow, which can happen in 25% of people, then they turn into what we call a subependymal giant cell astrocytoma, or SAGA. And the challenge with the SAGA is that if it grows or becomes too big in a certain location, it may lead to obstruction of fluid flow in the brain or hydrocephalus, which can be quite dangerous. And they also may bleed or rupture, which can also be quite dangerous. And so for SAGAs, we tend to be quite aggressive in our treatment, either with an mTOR inhibitor to help suppress the growth or even shrink the tumor. And if that's not tolerated or a good option for the patient, then we may move on to a surgical intervention, such as a resection or a laser ablation. The fourth main neurologic complication of TSC is called TAND, or TSC-associated neuropsychiatric disorders. This is becoming one of the more well-studied and larger areas of interest right now in the TSC Alliance and the TSC Consortium. And the reason for this is you can see, as an umbrella term, it really encompasses 6 main areas of neuropsychiatric and neurodevelopmental challenges. Patients with TSC have up to 90% of patients with TSC will have an associated TAND disorder, either ranging from intellectual disability, developmental delay, autism, ADHD, anxiety, depression. And so you can see how this can be quite challenging to families and patients who are struggling through TAND. And so currently, our best treatments for this include supportive therapies like physical therapy, OT, speech therapy, as well as medications as needed for the neuropsychiatric challenges. Moving on to the non-neurologic complications. So intracardiac rhabdomyomas are seen in up to 50% of patients. Interestingly, this is often one of the main referral base that we get for kids with TSC. It can be diagnosed prenatally, and so as early as 22 weeks on a fetal cardiac echocardiogram, we can see these rhabdomyomas, and often our cardiac team will refer them to our clinic once the baby is born, and then subsequently get evaluated for tuberous sclerosis. The interesting thing about the cardiac rhabdomyomas that sets them apart from the other challenges with TSC is that they often regress on their own, so they tend not to need any sort of intervention, and usually do not cause any significant problems unless they're leading to an arrhythmia or some sort of obstruction of the cardiac outflow. The second non-neurologic complication, which is one of the hallmarks of the disease, are the dermatologic manifestations seen in almost everybody with this disease. And you can see on the upper left are the hypomelanotic macules. On the upper right, we see a collagenoma, or area of increased collagenous tissue formation called a shagreen patch. Sometimes it's called an orange peel patch because it tends to have a texture and a look of an orange peel. In the middle, we see the facial angiofibromas, another one of the hallmarks of the disease that many patients will experience. And then on the bottom two photos, you'll see the ungual fibromas, or the growth in the nail beds, and the fibrous cephalic plaques over here. 10 patients can have growths on their forehead. In the eye, we have retinal hamartomas, and these tend to be asymptomatic as well unless they are growing over the optic nerve, in which case it can lead to some vision obstruction. In the abdomen, we can see angiomyolipomas. They tend to be most often in the kidneys, which is an example here. You see an area of cellular overgrowth with some vascularization. And then on the right-hand side of the screen, you can see renal cysts. And interestingly, the TSC2 gene is next to the polycystic kidney disease gene. And so sometimes patients will have features of both diseases. If you have pretty significant renal involvement, you're at risk for hypertension and renal dysfunction. And so sometimes that can be a major complication to manage as well. And finally, the last non-neurologic complication is lymphangioliomyomatosis, or LAM. Interestingly, in LAM, it's most commonly seen in older women, so not something we tend to deal with in our patient population at Children's, although we have had a couple of cases. And you can see in the lungs here, inside the pleura of the lungs, you can develop cystic formation. And with the cysts that form, they put the patient at an increased risk of lung collapse or pneumothorax, and so certainly can be a quite severe complication. So the non-neurologic treatments of TSC, you'll see a theme that for some of the challenges, we don't need any treatment. So the cardiac rhabdomyomas, I mentioned, tend to shrink on their own. If they cause an arrhythmia, a patient may be on an antiarrhythmic medication. We have had some children who had cardiac dysfunction related to their rhabdomyoma and who needed a brief course of an mTOR inhibitor. I mentioned the retinal astrocytomas tend not to need intervention. The facial angiofibromas, we have an FDA-approved cream. That's a topical sirolimus or mTOR inhibitor. And then for the pulmonary and renal complications, we can use systemic mTOR inhibitors such as everolimus to help with those, as well as antihypertension medications if the patient has that as a complication of their renal disease. So in 1998, the TSC Alliance and the Physician Consortium came together and created diagnostic criteria, and these have since been revised with the most recent revision in last year, 2021. And you can see there are 11 major criteria for the disease, and we reviewed all of those today, and 7 minor features. And so to have a diagnosis, you have to have either 2 major or 1 major and 2 minor criteria. You can also have a genetic diagnosis, and I think this sometimes gets a little bit confusing, and to some extent to what Dr. Mirzaa was talking about earlier, where a person might have genetic testing for one reason, and come up with a positive TSC mutation and not really have any of the outward signs of the disease, but still have TSC. As part of the consortium in 2021, we've updated our surveillance and management guidelines. You can see here, because this is a multi-system disease, most patients will follow with multiple physicians or practitioners and have frequent surveillance screening done of their brain and their abdomen. One thing I'd like to highlight as a recent change, we've now been doing EEGs regularly in the first 2 years of life to help look for risk of seizure and prevention of seizure. So I'd just like to spend a few minutes to talk about the TSC Alliance and our program here at Seattle Children's. So the TSC Alliance is a patient support group that started in 1974. It was brought together by 4 mothers of patients with TSC, and since has been an amazing organization that's really helped drive research, understand the disease process, and heighten awareness. They also have a pretty rigorous screening program for clinics across the country and outside of the US. And as you can see, this is from their website of the approved clinics. A large, clumping over here on the East Coast and Midwest and in the South. But up, you can see in our Northwest, we've been an approved clinic since 2017 and really serve a large population of our country. As part of our program, I work with my partner, Dr. Owens, who will be speaking later today in the epilepsy piece of the TSC program. And we're supported immensely by our TSC nurse, Allison Cantorano, and our administrative team and scheduling team, Claire and Lydia. We also have brought together specialty physicians in each of the important areas of involvement. So we have a dedicated provider in each area you see listed here who is knowledgeable and experienced in taking care of kids with TSC. We have a quarterly clinic where we work in the same clinic space as dermatology, next door to the ophthalmology clinic, and have a genetic counselor present to help really provide a comprehensive evaluation for our patients who need it. And then we have twice monthly TSC and epilepsy clinic to really allow for accessibility. You can see here I've listed the goals of our program, which I think we've really reached most of them since we started it in 2017. One of the things I really wanted to do is be a medical home for our patients and making sure that they're getting those tests and appointments that they need every year, making sure that we're giving the best care we can. We're involved with the most up-to-date research and community activities. So I'd just like to talk about a couple of trials that we're doing or have done and next steps for our program. So the newest trial that we're enrolling in is a study looking at the use of MRI scans and whether or not we can get away with a really quick MRI, which we call a haste MRI. It takes about a minute, versus a full conventional MRI scan, which takes up to 30 minutes, often requires sedation for young children and children who can't lay still. And what we're going to do is compare the results of both studies to see, well, is the quick MRI good enough? And hopefully, if we're able to prove that, then we would save time, money, sedation. Lots of good things could come from that. So we're enrolling for that right now, so we'll stay tuned to the results down the road. The PREVENT trial was a multi-center study done in about 20 centers across the country. We were one of them, looking at the use of anti-seizure medicine vigabatrin in preventing epilepsy and developmental delay in kids with tuberous sclerosis. This study is closed for enrollment, but we haven't completely finished collecting the data, and so in January, we should be able to have our last patient enrolled and hopefully have some positive results. So stay tuned for that. Working with Dr. Sinedo, who you'll hear from later today, we're going to be starting a study with the Marinus group looking at the use of a drug called ganaloxone and whether or not that may help with improving seizure control in patients who have refractory epilepsy. And then finally, the most recent study, multi-center study that's on the horizon that we're, I think, pretty excited about in the TSC consortium is called TSC STEPS. We're not currently a site, but in the process of becoming one. And some of our patients here who are involved in that research study have gone to Cincinnati or Stanford to be part of the study. But that is a study that just started enrolling in the last few months, looking at infants with TSC and treating them with an mTOR inhibitor called sirolimus to see if that prevents seizures and developmental delay. So I'd like to thank you for your attention, and if you'd like any more information about our program or any questions about TSC, feel free to reach out. And with that, I'll let Dr. Hauptman come up next.
Before I get started, I just want a round of applause for everyone who's been on the panel so far. And I want to point out Dr. Novotny, Dr. Randle, and our unsung heroes sitting right there, Julie Wilson and Patty Kilburn, who really put this together. And so a round of applause for
Dr. Hauptman.
Thank you so much.
Hey, Dr. Hauptman, it's Patrick. Can you flip your badge around or take your badge off?
Oh, yeah,
Thank you. Sorry.
Thank you. I don't want to, no badge. So my name is Jay Hauptman. I'm a neurosurgeon for children. I'm an epilepsy neurosurgeon. And I've spent my entire career, really thinking about how we could better treat children with intractable epilepsy. And I am lucky to have phenomenal partners here across the board, in surgery with Dr. Goldstein, Dr. Ojeman, and in neurology with all the fantastic speakers here. For the next 15 minutes, I'm the guy between you and lunch. I am cognizant of that. And for the next 15 minutes or so, I'm gonna go over a lot of different ways that we try to cure. Dr. Goldstein and Dr. Bozarth did a terrific talk on options we have for neuromodulation when we think cure is probably not the direction we can go in. And so we're gonna kind of talk about the other road when there's that fork in the road as to what we call palliation or cure. And I'm gonna try to do it in a way that I think is accessible, and so hopefully it'll spark some questions in the discussion. I have a few disclosures, none of them are relevant here. And I'm gonna go over some stuff that many of you have probably heard before, but it's fundamental to what we do. Treatment-resistant epilepsy has a very specific definition. That definition has been in existence for the better part of 20 years, and it came from a natural history study that was done in New England before I was right around when I was a resident, in which all they did was they looked at children who were diagnosed with epilepsy early in life and just followed them, okay? Had them see their neurologist, had them started on anti-seizure medicines. All they wanted to know was what did the future look like for those kids. And what they found is that when kids were on 2 anti-seizure medicines, and they kept on those medicines because the side effects didn't keep them off those medicines, if they were not at 0 seizures, the addition of a 3rd or a 4th medication just didn't get them there, at least not 95% of the time. And unfortunately, it didn't really matter whether it was the oldest medicine that we have on the books, which is probably phenobarbital, or the newest ones. If these seizures are associated with something on MRI, like what we call brain lesion, the chances are even lower. And we in neurosurgery feel pretty strongly that if we push the medicine beyond that 2 medication threshold, we might be doing children a disservice because the seizures are probably continuing to affect development and all the things I'm about to talk to you about today. So for us, treatment-resistant epilepsy is a failure of those 2 medications. As a surgeon, I get asked all the time, why would you do brain surgery for my child when I was always under the impression my child had a medical problem, not a surgical problem? And the answer is, we think we can help. And not only do we think we can help, but we also think that any of the interventions that we perform as neurosurgeons have a much lower chance of hurting your child than the continual onslaught of seizures during the childhood, okay? And that's like the fundamental principle that underlies epilepsy neurosurgery in children. We know that greater than 60% of children who have intractable epilepsy from the temporal lobes, they'll go on to have some intellectual disability. It can be significant, especially if it starts in the first 24 months of life. We know that seizures, when uncontrolled, can affect all cognitive domains of children, and that's something Dr. Patrick and Dr. Bowen see all the time when they're evaluating our children in our neuropsychology clinic. We know that suboptimal seizure control can result in poor quality of life, poor psychosocial outcomes, being able to forge friendships, being able to identify with your peers, being able to finish school, being able to hold on to a job, being able to finish college, have meaningful relationships later in life. We know that if we intervene early and we cure kids with epilepsy, that they get better. We can get normalization or improvement in things like IQ scores and developmental indices. But more importantly, we know that if we can achieve 0 seizures, we reduce mortality. And seizures, unfortunately, are a mortal disease. Sudden unexplained death secondary to epilepsy, what we call SUDEP, has a risk rate of 0.5 to 1% per year cumulative. A child that lives 20 years with uncontrolled epilepsy has a 20% mortality. And that's just unacceptable. It's unacceptable in our world. And so we want to do better. We also know, like I alluded to earlier, that if a child has a lesion on their brain MRI, a low-grade tumor, cortical dysplasia, or even tumors associated with tuberous sclerosis, the chances of medicines controlling seizures entirely are much lower. And in fact, we are now embracing what we call the one-drug failure, meaning that if a child has an MRI that shows a brain lesion that we think is responsible for the epilepsy, and they are currently on one medication and still having seizures, the likelihood of even adding a second and controlling the seizures to 0 is low. And so we are now considering children with only one medicine in epilepsy surgical candidates. So that's something new that we've been doing over the last several years that has really informed our philosophy for taking care of your children. We know we could be doing better. This is a survey I have been showing for years every time I give talks like this. This is from the ILAE. This was a survey of all pediatric epilepsy centers. It's now about a decade old. But what you see on the left-hand slide is the age at which seizures began in children who were referred to an epilepsy surgery center. And you see that the majority of them were started really early in life. But when you look on the right side of the screen, you see how old these kids were when they got to surgery. And you can see that that shift is all the way to the right side of the graph, meaning that even though their seizures started earlier in life, it took a decade or longer for us to be able to evaluate them for epilepsy surgery. And a lot of work we've done over the last 10 or 15 years has been to increase awareness and advocacy and early referral to a comprehensive epilepsy center so that we can see what the options are and perhaps shift that graph back over to the left and reduce the duration of the epilepsy between onset and surgical evaluation. Everything that we do in epilepsy surgery is absolutely a team approach. It requires a tremendous number of very motivated, talented, and committed professionals to guide our children from first referral to surgery. This is what that looks like. And everyone that you've heard from or are going to hear from today has a spot on this tree. And so we start with the referral. We evaluate children comprehensively, electrically, using things like scalp EEG and some of the surgical techniques I'll show you. Imaging, we have incredible imaging resources at Children's. I want to point out two people who are sitting in the back who are not, front and center in front of the patients, but who are critical to what we do imaging-wise, and that's Mike Binschlader and Seth Friedman. If you can just raise your hand and just wave. These guys are responsible for the very advanced functional neuroimaging techniques that we're doing at Children's to help figure out where the seizures are coming from, really trying to push the boundaries of what non-invasive evaluations look like. You heard from Dr. Patrick and her partner, Dr. Bowen, who make up our neuropsychology team, who try to figure out where functionally kids sit with regards to how their epilepsy is affecting them, both so that we can track how they're doing after surgery, but also to find perhaps areas of brain regional dysfunction that can help clue us into where the seizures are coming from. I apologize in advance for any brain pictures I'm about to show you. There will be a few coming. It is before lunch, not after lunch, so I feel like I have a little bit of timed appropriately here. Perhaps one of the biggest surgical paradigm shifts in the last decade has been stereoelectroencephalography, or what we call SEEG. SEEG is not new. It's been around since about the 60s, mainly in Europe, but it was done in a way that was very technically laborious, and it would take an entire day of surgery just to place 10 or 12 brain electrodes or brain wires to figure out in a subset of kids where their seizures are coming from. But now it's advanced with the assistance of a surgical robot. We call her Rosa, she's French, to a minimally invasive surgery that takes 3 hours. And this is really important because in a lot of kids who have negative brain MRIs, and it's elusive as to where exactly in the brain these seizures are coming from, we have to go to the next step, which is put in brain electrodes, keep kids in the hospital and monitor their seizures so we can figure out where exactly these seizures are coming from. And the way I like to think about it, and I've made this metaphor in clinic countless numbers of times, is we don't want to know the country, we don't want to know the state, we don't want to know the zip code of where these seizures are coming from. We want to know they're sitting in the armchair in your living room at your street address, because that is what is going to focus our interventions so that we do a surgery that's safe and effective and minimally disruptive to areas of the brain that are not involved in the epilepsy. This is what stereo EEG looks like. This is a step that we use to get us there. The old way, I apologize for the brain pictures, the older but still very effective way that we have to use sometimes is where we put strips of brain electrodes on the brain surface. It's a bit of a bigger surgery and a bigger recovery, but there are things that we can do with this surgical technique that we still are working out how to do with the minimally invasive one. For instance, something called brain mapping. Has anybody in here heard the term brain mapping before? Brain mapping is a technique we use to figure out what areas of the brain are super important for function. When we think about language, sensation, movement, this is a technique we use to figure out which areas of the brain we absolutely need to preserve. Because even if we cure epilepsy, if we change a child in a way that they wouldn't like, or you wouldn't like, have we won? And so we want to win on all fronts. We want 0 seizures, and we want to give your child back to you in exactly the same shape that you gave them to us. And that's the goal every time. One of the most effective surgeries for epilepsy is something called a temporal lobectomy. In adults who we see who have refractory epilepsy, the temporal lobe is by far and away the most common place the seizures come from. And the surgery we do for that, which used to be almost entirely an open brain surgery where we remove the temporal lobe, we now have replaced a lot of that with something called laser ablation, which I'll show you in a minute. But it's highly effective, and it's actually the best studied epilepsy operation in epilepsy surgery. Published in the New England Journal of Medicine over 15 years ago, this randomized controlled trial demonstrated that surgical management is by far and away more effective than medical management for folks who have temporal lobe epilepsy. You can get 70+% seizure freedom with this operation, as compared to 5% with medicine alone. That is a huge order of magnitude increase for medical therapy alone, and it gives hope to a lot of people. Sometimes seizures are coming from outside the temporal lobe, in which we do something called an extratemporal resection, which is where we need to remove brain tissue from outside the temporal lobe. When there's a lesion on MRI, this is highly effective. This can be greater than 70% effective in children who have brain lesions on MRI. Sometimes we have to use stereo EEG to guide us. A lot of times when we're taking care of children that Dr. Randle takes care of as well in the TS clinic, those kids have tubers very frequently that are outside of the temporal lobe. And we have to strategize not only which tuber is the culprit tuber, but how best to take care of it, whether it be to remove it or to do something minimally invasive like a laser ablation, or even something like what Dr. Goldstein and Dr. Bozarth discussed earlier, neuromodulation. Getting back to the brain mapping piece of this, sometimes things that are causing epilepsy are really, really close to important brain areas that we want to preserve at all costs. Sometimes we have to be so precise about only taking out the area causing the seizures and not taking out areas of important brain function that we do surgery awake. I know that sounds very Hollywoodish and very dramatic, but we do a lot of it here at Children's because kids need it, and because our goal, like I mentioned earlier, is not only to stop the seizures, but to preserve everything. And in this surgery, kids are woken up, they're tested with regards to their language and their movement, and it is painless. And I know that that is hard to imagine, but one of the things that's incredible about the brain is the brain actually has no pain receptors. Only the scalp does. And so you can fully anesthetize the scalp, make it completely numb, no different than anybody who's had their wisdom teeth pulled out and was awake while doing it. And you can actually, through very gentle electrical stimulation, figure out exactly where those critical language areas are. The girl on the lower right-hand side, a couple of years ago, had an epilepsy, a very unique kind of epilepsy called musicogenic epilepsy, and a tumor that was right near her area responsible for processing sound that we actually did an awake surgery with her to preserve both her hearing and her music abilities. And it got some notoriety, but I think it really, more importantly, highlights how effective this surgery is in children and how safe it is to do. Sometimes we have to do big surgeries. Some of the examples of cases that Dr. Mirzaa showed with hemimegalencephaly, in which the entire half of the brain is affected, we actually disconnect an entire half of the brain. And I know that sounds dramatic, but it is the most effective operation I can do for hemispheric epilepsy. And kids do incredibly well. You would think after disconnecting half of the brain or a hemisphere that kids would live the rest of their lives debilitated from it, but they don't. And the younger we do it, the faster and better they recover. We have several kids a year who unfortunately require this, but greater than 90% of them are seizure-free, many of them having hundreds of seizures a day or a week prior to hemispherectomy. And we have a terrific rehab program here in which right after surgery, we get these kids in intensive rehab, and I'll tell you what, a year later, you would have a hard time believing that they had a hemispherectomy. Walking, talking, throwing a ball, catching a ball. I mean, it's really incredible. This is something only kids can recover from. And again, the earlier we do it, the better they do. This is a minimally invasive approach that we adopted here over the last 5 or 6 years. We call it laser ablation. It is through a tiny incision the size of our pinky fingernail, in which we can actually, using a laser under MRI, heat up tissue and disconnect it from the rest of the brain. And this has become a very common now alternative to the traditional open surgeries like temporal lobectomy, and then also we're doing it for pediatric brain tumors. This is what it looks like. If any of you have heard of hypothalamic hamartomas, they cause a very particular type of epilepsy called gelastic epilepsy. This has now become the mainstay of therapy for hypothalamic hamartoma. This is what we do now. And I'm gonna finish, I think I have like 1 minute left. Does that sound about right? 2 minutes left. Oh, one more than I thought. Overall, between 65 and 80% of children can be seizure-free after surgery. A lot of that depends on the why we're doing what we're doing, whether they have a positive brain MRI or not. We know that kids who have temporal lobe surgery, they do really well, just like that graph I showed you earlier about temporal lobectomy. We know that if seizures stop early after surgery, likely they will continue to be stopped years later. And we know that up to half of kids who are seizure-free after an epilepsy operation can be off medication as well. And that's life-changing. I mean, how many parents, really think the worst thing about the epilepsy are some of the medicines that we use to treat them and the side effects secondary to those medicines. We know that after surgery, developmental quotients can improve, developmental velocity can be restored, caregiver assistance can be reduced. That means parents are getting back to, not feeling like they're sacrificing attention to their other children, being able to get back to work, less stress, less days off of work secondary to epilepsy. These are all impacted. We know that in kids, IQ, behavior, attention can all improve or remain intact. And kids, more importantly, or perhaps even most importantly, they feel better about themselves. Quality of life, indices significantly improve after satisfactory epilepsy surgery. Kids feel higher self-worth, higher social competence, better athletic competence. They're, happier in general. And I think it's understandable when you're struck with a disease that can strike at any moment. I'll kind of end with this. Fortunately, in modern neurosurgery, complication rates are really, really low. But more importantly, they are way lower than the natural history of intractable epilepsy. And so most surgical risks are in the 1% to 2% range, even for the big operations like hemisterectomy. And so really on all fronts, a lot of the operations that we offer for epilepsy surgery, they make sense and they're effective and they're really safe. And so with that, I'll close. And again, I just want to thank everybody for their attention.
So we would be happy to take any questions from the audience or the WebEx. Yes, we would be happy to provide the slides. The talks today are going to be recorded. And what we could do is have maybe a sign-up sheet with your email if you're interested. Next year, we hope to have everything printed out. So that's on our to-do list. Yeah, JR, if you'd like to ask your question and then, you need a microphone. If you just slide the...
Okay, the question is, should it be the general practice and FCD to test the brain tissue for genetic cause?
This one? Yeah, there we go. Thanks for that question. So in general, we say that if it's possible to test, if the child is getting brain surgery and it's possible to get the brain tissue tested, absolutely. However, there's a lot of steps that need to happen in order for that to work out, right? So, and we always acknowledge and respect that not all families have access to these resources. So by no means do we want to make it sound like this is easy to do anywhere in the world or anywhere in the country, because some centers are well equipped to do this, and we're fortunate to be in a center that is equipped to do this, but other children may be seen like at centers that might not be. So, but in general, absolutely. Just to kind of figure out the cause of the epilepsy, if there's a genetic risk factor there, it's absolutely worth it. It does require planning ahead and talking to your neurologist or your geneticist about this to help hopefully get things lined up to do that. But all the tools are there to get it done. I do think it's a good idea for the child's medical care in general, because it does help, again, explain the root cause. If the child, hopefully that doesn't happen, but if the child has seizures after the surgery, having the genetic piece can be helpful. So it is, for FCD, there's enough data now to show that a lot of kids, especially with FCD type 2 specifically, a lot of these kids can have a genetic risk factor, actually, or a genetic cause to their FCD. FCD, just to be very specific also and clear for some of our families, and I think Dr. Bozarth and Goldstein showed a few patients, FCD types 1 and 3, there's other types that we don't know if they're genetic. Some of them are not actually genetic, but FCD type 2 can actually be highly genetic. So yeah, absolutely.
If you don't mind, they'll bring you the microphone.
Hi, my name is Karen Pratt. I'm a mom of 2 kids with the ultra-rare disease, is WWX, epileptic encephalopathy. And I'm just learning a lot here. And one of the things after the last doctor spoke that I was very curious about is, when do you start that conversation about surgical intervention? Because in most of our families, our kids are in like 3, 4, 5 anti-seizure drugs. There are always differences. MRI, in my 2 sons, they have thin corpus callosum. That is the difference. In my youngest has macrocephaly. But with most of families, we never hear any neurologist suggesting something above medication. And I mean, listening to what the doctor was saying, I'm like, there is more hope than just keeping our kids with all this huge amount of medication. And I've seen it in my sons, like my oldest, we were able to wean 2 of them, and he's doing so well at school. So I'm wondering when us as parents can advocate for exploring surgical intervention to reduce that huge amount of anti-seizure meds.
I think that's a great question. I think as a parent advocate, once your child is on 2 medications, I think that's the time to really start thinking about having an evaluation at a center that offers surgery. The spectrum between what I presented and what Dr. Bozarth and Dr. Goldstein presented is indeed that. It's a spectrum. It's not a dichotomy. It's not one or the other. We're thinking about all of these things. And in kids who don't necessarily have a cause of their epilepsy that we think we can cure without harm with an open surgery with the intent to cure, all kids are candidates for vagal nerve stimulation, and many of them for DBS and RNS. And what we're working on now are expanding the indications for those latter 2, the deep brain stimulator and the responsive nerve stimulator. And we're finding that a lot of kids that would not have had surgery otherwise are finding benefit with these devices. And the motivations are exactly those. I would love to see if my child, we can reduce the amount of ASMs they're taking. We'd like to improve their quality of life. We'd like to maybe reduce the amount of caretaking I need to do so that I could perhaps, focus on my family, my job, and those are very, very reasonable considerations when we think about it. But I would argue that it's really never too soon to at least talk about it and think about it. Sometimes we have parents whose kids are medically controlled and they just want to talk to us about the what if. What if we get to that day? And I think that I'm a parent of 3 kids, right? And like one of the hardest decisions that parents of children with epilepsy need to make is when do we flip that switch? When do we start thinking about brain surgery? And so I really appreciate the gravity of that decision. But I would say that when you look at it in the rearview mirror, when you've thought about it earlier and talked about it earlier, I think you're going to find that you feel really good about that. You know, you've provided your child with all options that are available.
Can I say one thing, Jay? Sorry, I just want to comment your question. It's never too late to go with the surgical route.
Thank you, Liang. That's a really, really, it's never too early and never too late. Yes. Thank you.
Okay, the SUDEP statistics sounded quite high. AAN guidelines suggest discussing SUDEP as an annual risk impacting 1 out of 4,500 children and 1 out of 1,000 adults. This can be a scary statistic, so just wanted to get clear and possible realistic expectations.
I think the statistics vary according to what study you look at, but a lot of the foundational work that's been done in pediatric epilepsy surgery, you know, is centered around the likelihood that that statistic is a bit higher. It's not to scare, it's to help parents balance the decision-making about how aggressive to be when it comes to the care of their child's epilepsy. And whether that percentage is 0.5% per year, 1% per year, or 0.25% per year, all of those are still strikingly higher than the risks of any interventions that we offer surgically. And in exchange, you get a chance at seizure freedom that's an order of magnitude higher than with medication alone. One of the more interesting things is a lot of the work Dr. Goldstein presented with VNS, RNS, DBS suggests that even if we get not cure, but reduction, we can modify the SUDEP risk with that too. We can lower the SUDEP risk. And that's really interesting and something that we're really embracing, again, looking at all avenues of surgical therapy. I don't know if anybody else wants to add to that, but.
Okay, the next question. There is genetic testing available for medications which can be tested against the genetics of a child for efficacy of the medication, similar to medications which test for allergy based on genes. Is this something that is being reviewed as tools for epilepsy management?
I think I understand the question to some extent. I think is it genetic testing for specifically looking at response to medications? Could you rephrase?
I just read the question. They did end with gene site testing for epilepsy medication, if that's helpful.
Yeah, I believe what the person is asking about is about what we call pharmacogenomics, which is, there are genetic factors that impact how the child responds to different medications, particularly anti-epilepsy medications, among many other types of drugs, in the way that the body handles the drugs and metabolizes the drugs and things like that. And so broadly, this is called pharmacogenomics, which means our genetic ability to metabolize drugs differently, and these differences can be quite important for how the child responds to different medications. I hope that's kind of the question. So yeah, there's genetic tests available for that, and certainly when to think about those tests really depends on how the child's course has been and how they've responded to anti-epileptic drugs, the ones that they've been placed on throughout their epilepsy course. And our neurology colleagues really have even more experience in this than probably us in genetics, because they tend to manage a lot of these issues very actively. So, but these are actually definitely a factor sometimes in how the child may or may not respond to certain classes of medications. So that's one part of it. And then there's the other part, which is that if the child has actually a genetic syndrome or a genetic condition that makes certain drugs, better anti-epileptic drugs to control their seizures. There's certainly a whole list of genetic conditions where the child may respond to a certain class of drugs better than others. So knowing the genetic piece also says, helps us kind of figure out, okay, these are the drugs that would be great for seizure control. And and sometimes we say that these are drugs that we should avoid, actually. I hope I'm understanding the question, though. Okay.
Yeah, They confirmed it in the
Yeah, of
chat,
course.
so.
Yeah, yeah. But in general, just to kind of kind of circle back to that, is that I think if any parent has concerns about that, honestly, the best advice I can give them is have a conversation with your neurologist about it. Sometimes, again, you might not have a geneticist on board right away as part of your child's care team, but talk to your neurologist about it and ask, these questions, because this is a really valid conversation to have, and see, and based on that, there's a lot of detail there that you can go down and explore further.
You might just want to use the handheld.
I don't know. I'll
Oh,
try
now
to
we can hear
talk.
you.
Okay. So I think from my perspective, from my side of what I do with my patients, so clinically we do not do genome-wide study yet, like lots of patients with psychiatric disorders, they will target the drug, the gene testing. So right now we don't have it. Clinically, what I do, I use drug level testing. So so when a child tolerates the medication based on the drug levels, give you a good example is clobazam. Some patient has to very slowly get rid of the medication, so you only need a very low dose. Some patients, they get rid of the medication really fast, you need to go up the dose. But I agree with you, I think genomic-wide testing is the future. I think we'll get there soon. Thank you.
So I was really struck by the genetic mosaicism with the data that you presented, and I was wondering if you could kind of touch upon how you think precision therapy and just targeted gene therapy would be able to address this challenge.
Yeah, that's a great question, actually, and a question that I think a lot of us are, especially now in this era of gene editing and advanced, methodologies to model epilepsy, are kind of thinking about. So, for one thing, I think over decades, kind of what's happened is that over the evolution of our understanding of the causes of epilepsy, anti-epileptic drugs in general have gotten a lot more targeted than they were before. Previously there were what we call Band-Aid, right? Band-Aid solutions towards epilepsy, but now actually a lot of the drugs are extremely more molecularly targeted than they were before, which is great. A great example, I think, is the one that Dr. Randle actually mentioned. I mean, we think of that as a very targeted, in a way, drug, which is rapamycin or everolimus, which actually targets a specific pathway in the body, and it has been extremely helpful for a number of disorders associated with epilepsy, like tuberous sclerosis. So there's been things that have been happening over decades, right? That are, again, the whole trajectory of the field has been towards more molecularly targeted therapies. And this is really the future. This is where we expect things to continue to go. In terms of gene editing and more gene targeted approaches, these are actually also, they're still earlier in their stages of maturity, obviously, because we now have gene editing methods like CRISPR-Cas, what's called CRISPR methods, basically, where people can go in and manipulate our genetic code to either knock out or remove a genetic change or introduce a genetic change into the cell. These are extremely exciting and promising approaches that people are using increasingly now for a whole variety of conditions, and we expect hopefully to see a lot more of their utility in different genetic conditions. But they're also going to have to go through their journey of maturity, from anywhere from functionally understanding the causes of epilepsy in the lab or in a dish, all the way to hopefully clinical applications and clinical trials. And there's even other classes of genetic modifications, like something called antisense oligonucleotides. These, I think, if for any of you guys who if you go online, you see a lot of ASO-based kind of therapies that are also getting increasingly deployed. And sometimes, actually, they're starting to be used when we don't have to have hundreds of children who have the genetic condition. They can start with much smaller numbers into clinical trials. So a lot of this is happening over time. And I think for different genetic conditions, they're going to be, again, at different points of our maturity and understanding of these. So some of these might be way closer to clinical application for some of these gene modifications, and some of them might be way earlier, depending, I think, on which protein is affected and things like that. So I'm sorry, like it's a very broad, I think, answer that I'm giving you here, but I think overall, I think we're extremely enthusiastic about these. I do think it depends on the class of, epilepsy condition we're talking about and the type, but I think that these are going to be increasingly used. So precision-based kind of approaches is part of the reason why we started, I think, the Epilepsy Genetics Clinic in a way, and Dr. Novotny really spearheaded this many years ago, is because we wanted to kind of employ more precision-based approaches. And knowing the child's genetic background has definitely shown to be extremely valuable to put us on that first step on that path. I hope that answers a little bit the question.
Yes, it's great discussion. It's a very challenging question, so thank you.
Okay, the next question is, we thought our diagnostic journey ended when we received the diagnosis that our daughter's epilepsy is caused by a mutation of her CHD2 gene, which we found out by the whole exome sequencing of her blood. But after listening to today's talk, I am wondering if a more thorough diagnostic should be done to obtain, until her brain tissue is tested. Is that correct? Are they interpreting that correctly?
Possibly. So I would say, this is kind of where we would ideally need to really review everything for the child, to be honest. I will say that in general, the most common genetic causes for epilepsy in general are causes that are found on testing blood or, so there's these general genetic conditions that affect the child's brain, and usually these are the most common, what we call, epilepsy syndromes, are actually found on exome sequencing. CHD2 is a definitely well-known, well-described disorder that's associated with a host of neurodevelopmental disorders. So if that was kind of found, I would have a high level of confidence that it's contributing, at least to some extent, to the child's medical issues, because it's been very well described. Now, whether or not the child might have another genetic risk factor, which is kind of what I'm gathering from the question, or if there's something that's hidden in the brain, a genetic, mosaic genetic change, that it really depends on looking at the brain imaging, the child's seizure semiology and what the seizures look like and their EEG characteristics, and evaluating the child as well. So doing a really comprehensive exam. Is it possible that the child might have two things going on, genetically speaking, that causes their seizures, CHD2 and something else? Absolutely. And that's unfortunate, of course, to have more than one thing to deal with, but it can happen. So usually what I tell my families is what is our level of diagnostic certainty here, right? If we've had some evaluations, but we're still not sure that they explain the child's epilepsy, then it's okay to dig deeper and go further. And if the child is having epilepsy surgery, again, that kind of opens up the question of whether we should test brain tissue. And we've certainly, as our team combined, we've had many instances where we've thought about that. Should we go that extra step? Should we test the brain tissue, even if we had something else going on that was, in the background as well? Very valid question, but I would say it really depends on the MRI, the seizure, course, EEG, differences, taking all of those combined to really make an informed decision. So, this is part of the multidisciplinary discussions we have on almost a weekly basis. Sometimes, there could be a child's features might fit with CHD2, but they have other things that don't fit. So then it's okay to kind of, keep searching. Sometimes they all fit in that one syndrome, right? So, and it can be really hard, I think, for parents sometimes to know, is all of this explained by this one genetic change that my child had, the CHD2 genetic change, for example, or is their seizure course atypical or not classic for this condition, in which case I think pursuing other causes is a valid concern for sure.
Well, if there are any other questions, we're happy to take them. Otherwise, it looks like lunch has been set out, and we will rejoin around 1:15 for our last session. Thank you very much.